This is the a meeting of the Community Hospital Workgroup of the Task Force for St. Andrews Hospital. We're meeting, this committee is looking at how do we plan for a community healthcare institution on the peninsula after April 1 of next year, when Lincoln County Healthcare has said that our emergency room will be closed and the hospital will lose its accreditation. This committee is looking at a future beyond that point for St. Andrews as a healthcare institution on the peninsula. We're really pleased to have with us today the former CEO of St. Andrews Hospital, Peggy Pinkham, who's going to explain what critical access hospitals are and how important that designation will be to continue as we go forward beyond April 1st of next year. I did say last week, and I just hope that you get it in your head, that the community hospital form of organization is only one of a couple or three different forms that we might want to go to. It's the most transparent. It could also be the most controversial, because it involves a board elected by the public with bonding powers and taxing powers and everything that goes with being the public. So I've actually expanded our definition of this hospital, or health, let's call it a healthcare center, because we're actually thinking about expanding the definition of what a hospital is, or looking at it in an innovative way so that it covers the old things that we wanted, but also many new. So the Community Hospital Group is looking at continuing St. Andrews here on the peninsula. It may be in a different form or with a different name, but we know some minimum things that we want. We want emergency care, we want respite care, we want rehabilitation care, those beds that, where people can go to recover, et cetera. So we know those minimum things, but we're looking at some broader, expanded things that might also go into this hospital. But we absolutely, our group needs to be working on the continuing existence of what we have called a hospital in the past. It may get a new name, we don't know, but it won't be the direction that Lincoln County Healthcare was trying to take us, which was probably, in my view, down the road to nowhere. Right. So keep the energy up. This meeting is of particular interest because it talks about what a community access hospital is, and I think that's going to be a key ingredient of whatever it is that we call our new enterprise. Peggy's more the expert on all of these things. Peggy, who's well known to everybody, is the former CEO of St. Andrews Hospital, and she's going to talk to us about what a critical access hospital is.
This is informal. I didn't bring you any specific papers to pass out. My goal today is to give a broad overview of what a critical access hospital is, kind of some history of how the program developed, and to have you folks ask questions, because there might be something that you have in your head that's an important piece of information that I didn't cover. So I'm going to be very broad and general, and I want to make sure that there's time for questions. So I'm going to do a little history lesson. In the 1990s, there was a change in how the federal government was going to reimburse hospitals for the Medicare patients that they served. Now, Medicare are those folks typically that are over 65 that are using the hospital. And at that time they said, if we change the methodology of how we reimburse hospitals, the smaller rural hospitals are going to lose in this, and we could actually impact how rural America receives health care services via a hospital. So they created a program called the Rural Flexibility Program. And that came up, as I say, and I'm guessing in the mid-1990s. in order for a hospital to even consider whether they could get this licensure, the state had to apply to the federal government and say, we will help administer this program. The state of Maine, the Office of Rural Health and Primary Care, that's what it was called at that point. Today it's called the Rural Health and Primary Care Department. They just changed their name. They applied to the federal government and said, we will administer that program here in the state of Maine. So they are the state organization that works with the critical access hospitals. To be a critical access hospital today, I won't do the history on that, there are certain geographic definitions that you have to meet. Your average length of stay, average, can be no greater than 72 hours, 3 days. That you are licensed to have no more than 25 beds, and those are beds that can be used for acute care, or those are beds that can be used for, in the hospital world, we call them swing beds. In fact, I remember when someone from the Register came and wanted to interview us about what is a swing bed, they actually got down on their knees and they looked at the bed because they thought the bed would swing.
Oh, wow.
And what a swing bed is, it's a different level of care. When you are admitted to a hospital based on whatever it is that you are there for, in most hospitals you are considered acute. That's the definition. And there are a long list of different diagnoses that fall into that category. And it's depending on the type of care that you receive that you're considered an acute patient. If the care that you receive is not within that definition, in most hospitals, and you're still not well enough to go home or receive home health, in most instances, you need to go to a rehab place, such as Brighton is an acute rehab hospital, or to a skilled center. A lot of nursing homes now have skilled bed, and it's usually short term. It's for maybe treating. We'll say you're in a hospital and your diagnosis is you can come in with pneumonia. That's acute. But maybe you're also a diabetic and have high blood pressure. And maybe your diabetes got out of control while you were dealing with that acute phase of your pneumonia. What you can do in a critical access hospital is you stay in that bed, and the staff and the accounting department do a lot of different paperwork. You stay in that same bed, but the care that you receive is considered skilled, and it falls under a swing category of care. So the beds allow you to do various things and different things in order for you to recoup. And some of you I know have been in a swing bed. And the other thing that can happen, say you have a procedure that isn't appropriate to have in a hospital because they don't do it, they don't have the medical staff to do it. And I'll use total hip, where your whole hip is replaced and you have, the whole new process put in. So you go to a larger or a different hospital to do that. But you would like to recoup at home or closer to home. If you've had 3 overnight stays at the hospital that did your surgery, you can request to come to a critical access hospital and have your rehab done there. I would say the majority of critical access hospitals have great rehab departments. physical therapy, occupational therapy, speech, dietary, nutritional services. So you can get your rehab services in a critical access hospital. And a lot of folks who had procedures outside of the Booth Bay region came back to St. Andrews for their recuperation phase and rehab phase. You can also use that level of care, that designation of swing skilled for end-of-life care. We at St. Andrews created a palliative care program. I know there was a debate a couple of Tuesday nights ago, oh, we'll lose our hospice beds. Well, we never did have hospice beds because there is, it's very complicated, a different type of certification and process that you go through. And quite honestly, the reimbursement for taking care of someone at end of life, reimbursement was much better if you were in a swing bed versus if you were in a hospice bed. The staff were trained very similarly to folks in a hospice program, as well as the social service. And a key part here is, does your medical provider, your physician, what type of training do they have in palliative care? And several of our physicians went on to get specific training in the care of folks that were at end of life of palliative care. Why would a hospital want to be a critical access hospital? Well, can you guess? One of the reasons is there's a different type of reimbursement that you get when you're a critical access hospital. You have that designation of critical access hospital. And here again, I'm going to go very broad. You receive your allowable costs. I'm talking about costs, not charges. And I'll give you an example. The costs in a critical access hospital in the month of September are $100,000. And during the month of September, you 75%, I have to do easy math here, 75% of the inpatients you had were Medicare, and 50% of the patients that you cared for on an outpatient basis, that's lab, radiology, rehab services, those are all allowable services under this program, were Medicare. So in theory, we'll just take that inpatient stay. So we'll say the cost, now this is staff, supplies, overhead, was $100,000. 75% of the patients that you treated on an inpatient basis were Medicare. So in theory, for the month of September, you'd be recouping $75,000 of your costs. You folks following me? Now, obviously, there's 25% of your patients that are maybe main care or commercial or private pay. But that was how the federal government set up the critical access hospital program. And the federal government said this only covers Medicare patients. When the program came to Maine, the administration at that time said, well, we'll cover or we'll include the main care population. So in Maine, they used that methodology for both Medicare and main care. And the hope was that it would keep you even, that you wouldn't lose money based on the number of folks that you were going to care for. And it's also true that the rural hospitals usually have a higher percentage of Medicare than some of the larger mid-size or tertiary hospitals, because they offer a wider breadth of services, and they might have a larger commercial population than the rural hospitals do. So this actually was a good program that the federal government put together to maintain access to healthcare services in rural America. And today, the last thing that I read is that the cost of the critical access hospital to the federal Medicare program is only 2% of their entire budget for Medicare. So the critical access hospitals don't take a lot of federal dollars to maintain, those. But it makes a huge difference for those hospitals that have the designation of being a critical access hospital. Maine today has 16 critical access hospitals. There are 39 hospitals in Maine, and 16 of those have critical access hospital status. Nationwide, there are about 1,300 critical access hospitals. Another thing that critical access hospitals enjoy is that the Office of Rural Health, on our behalf, can submit for grants on an annual basis that are used to support critical access hospital. About $350,000 a year the state has received from the federal government that critical access hospitals use. And I should reveal right now, that's one of the jobs that I do. I'm a consultant with the Office of Rural Health and Primary Care, and I work with the Maine's 16 critical access hospitals. Actually last week, we had a meeting with the 16 critical access hospital CEOs, or at least they were all invited, not all of them came. I work with the nurse execs from the critical access hospitals, and I'm also doing a project with the quality folks within the critical access hospitals on looking at quality measures, patient satisfaction. We're looking at many other things that hospitals today, whether you're a critical access hospital or not, have to measure to demonstrate quality. So that's another benefit of being a critical access hospital. From a physician perspective, looking at the critical access hospital program, that there's really no additional reimbursement for physician practices, but if you look at those physicians that are in the emergency room, they do fall under those allowable cost centers. Now there are some things that aren't allowable, and I do need to let you know that from if you're working in the finance department, to understand what's allowable and what's not allowable can be very confusing. And when St. Andrews became a critical access hospital I should know this, I don't remember, it was in the late 1990s. It was 96, I believe. At the same time, we were looking at developing the St. Andrews Village. And we didn't do a good job in separating out those expenses that were appropriate for, that fell under the critical access hospital program, and those expenses that fell outside the critical access hospital program. So for years, we were doing catch-up, and we were not given the full reimbursement that we were entitled to by Medicare, but it took us probably 8 to 10 years to get that all straightened out. And the last year when I was at St. Andrews was one of the years that we actually kind of put that whole issue to rest with Medicare. And so we received a sizable, I can't say it was a check, but we received a sizable amount of money from Medicare for all of those years that we were in negotiations with them on what we felt they owed us and what they felt that we owed us. We started out on the wrong foot. So it was a hard lesson to learn, but we got through that. The critical access hospital regulations require that you're a hospital and you provide certain types of services. And one of them is an emergency department. The regulations do give you a lot of latitude in how you staff that emergency room. You actually don't have to have a provider. And when I say a provider, it could be a physician, it could be a nurse practitioner, it could be a physician's assistant. They don't actually have to be in the emergency room. They could be on call, but so many minutes away, 15 to 20 minutes away. So you have a lot of latitude in how you staff that emergency department. I will say, though, in Maine, the expectation of staffing an emergency department is that you do have a provider in the emergency room. You don't have someone on call that comes in when the patient appears. And even though the regulations allow some flexibility, you also have to look at what is customary and usual for the area that you live in. Because if an individual walks in the emergency department and the staff say, oh, well, we have to call Dr. Smith or nurse practitioner Jones in, you know, the perception might be that you're not functioning like an emergency department. And all of the critical access hospitals that I work with in Maine have 24/7 staff. It's a mix, however. Most of them have all physician staff. They're not board certified in emergency medicine like you'd expect in a tertiary center like a Maine Medical Center and Eastern Maine Medical Center. But they're physicians that might have been primary care physicians that have had additional education in emergency medicine. They might supplement that with a nurse practitioner or a physician's assistant that has additional education in emergency medicine. The nurses, most of them get, I think it's CEN, Certified Emergency Nurse certification. So the regulations speak more to what is required of the staffing of the individual providers that care for the patients versus the other types of services. It also allows for a lot of flexibility in what I call clinical support services, whether it's lab, radiology, respiratory therapy. But again, you want to be on par with those type of hospitals that are your peers within your state. Most, I would say probably all, but I don't know that for sure, would expect you'd have lab 24/7, radiology 24/7, and perhaps other services to support an emergency department. A freestanding emergency department is very rare. I've recently learned that Maine General is going to be allowed to have a freestanding emergency room when they merge their two facilities in Waterville and Augusta. Their new facility will be in Sydney, I think. Is it Sydney? But they will maintain a freestanding emergency department in Waterville, and they'll have lab radiology, other services there to support the emergency department, but they won't have any beds where patients will stay, so they will have to be transferred depending on their need. But you know, I've heard a lot of discussion at these meetings, well, let's just have an emergency room. And the message that I want you folks to understand is there's a lot more to an emergency room than just a physician in a room. You have to have access, quick access to some of the diagnostic services that I just mentioned. Because if you're going to do a transfer, the physician and facility on the other end that's receiving that patient will want to know some of this information. You have to make an informed decision about where you transfer and what's the most next appropriate facility to make that transfer. So an emergency room by itself, you know, we should recognize that isn't something that is, I feel, is appropriate to even consider. And I think one of the reasons the Waterville freestanding emergency department will be able to stay is because of their volume. I mean, they do 20 to 30,000 folks a year. That's a lot of folks going through their emergency room. So the critical access hospital designation does, I mean, there's regulations like this that you must follow that include how the hospital is governed, how it is, types of clinical services, what type of quality program you have. So their risk management program, compliance program, I mean, there's a lot to running a hospital. It's not an easy thing to do, and you have to have specialized folks in all of those areas. I think for the 11 years I was the CEO at St. Andrews, very few clinical people were hired. We would hire clinical people if the volume changed. In particular, the rehab services at St. Andrews expanded over that period of time. And of course, when St. Andrews Village came on, that was another story as far as recruiting staff. But many of the folks that were hired during that period of time were in the quality department, or were in the finance department, or were in the accounting department. Because how you build for patients, how the numbers that you put on a sheet of paper that went off to an insurance company, if you didn't get those numbers right, those numbers became what they would say is what you were owed in money. So it was all the support services that, whether you're a critical access hospital or whether you're prospective payment, a PPS hospital, there are a lot of external forces that are demanding things from a hospital. The quality metrics that we had to measure, they come from the federal, they come from the state, they come from business partners. So there's a huge amount of quality work, whether it's looking at the outcomes of patients after they've had surgery, or patient satisfaction surveys. I'm sure any of you that have been in a hospital, you will receive a survey in a short period of time after you're in a hospital. And those are all calculated, They're all publicly reported. You can see all of that stuff, how your physician took care of you, what type of communications you had with your nurse, how were the discharge instructions given, all of those things. Whether you're small or large, you still need to have all of those outside, not outside, but I hate to call them back office functions, but because they're very important. Support services, the non-clinical support services that make it all run. It's just, it can be, it's very complex and convoluted. And charges don't necessarily reflect your costs either. And that's a hard concept to understand as well. But I'm not going to get into that because that's not what I'm looking for. So that is truly a very high level explanation of what a critical access hospital is. Questions?
How important is it that we keep the critical access designation here as we go forward with a different plan?
Based on what I know today, and I've been out of the, the in-depth detail of reimbursement and all of that, I would say it's very important. There are folks that are concerned, as I was, that this program is vital to those hospitals that meet the criteria because they are recognized and paid differently. But with that designation, you have to recognize everything else that goes with that. So unless there's a different model of hospital care out there or licensure that I am unaware of, I think for what we have today, that's extremely important to maintain.
Based on what you've said, Peggy, it seems that the costs related to in a critical access situation, the costs related to a Medicare patient, a Medicaid patient, and most emergency room patients are covered.
The costs.
The costs, not the charges, but the costs. So you're taken up to essentially almost a break-even situation by those particular patients.
That's
that correct?
The theory. That's correct.
And then my second question is the support staff, back office, whatever. Is that still in place at St. Andrews to any great degree, or has that all been merged together under Maine Health?
I can tell you what it was when I was there. We had integrated the finance departments of Miles and St. Andrews. And so we had one finance department, and that was, I don't remember when that occurred, but it occurred when I was the CEO. And we had one chief financial officer. He's still there today. His name is Wayne Printy. And he was responsible for both the financial operations of St. Andrews and Miles. Many of the management of the finance department, those like the controller and the business office manager, and those department managers were on the campus of St. Andrews that serviced both St. Andrews and Miles. But there were some individuals that made much more sense to be located at Miles, like patient accounts. A patient comes in, they want to talk about their bill. So how that's today, I really don't know.
There are 16 critical access hospitals out of 39, less than half. Is Miles one?
Miles is not a critical access hospital. They had the opportunity to be a critical access hospital when the program first came to Maine, and my history is correct, I believe, they opted not to do that because they felt that they needed more than the 25 beds.
Okay.
Now, when the program first came,
You don't need more than 25 beds, do you?
well, there were some changes in the program.
Because we don't have 25 beds.
We don't occupy 25 beds, but the feeling by some hospitals who were on the cusp of whether they needed 25 beds, less or more, chose not to go into this program because that's all you could be licensed for. And at the time, I believe that you had to designate so many beds that were acute and so many that were swing. And then the regulation changed that said you could use those 25 beds for either acute or swing. So you could have 25 acute patients in there, or you could have 25 swing patients in there. When that regulation changed, a lot of those hospitals that were on the cusp said, we're going to choose that designation because maybe our census fluctuates between 23 and 27. But some hospitals in Maine actually chose to seek that designation because of the reimbursement they were going to get. It far outweighed the negatives. It still allowed their physicians that were practicing in their community to do the majority of things they needed to do. And it was a better financial model for them. And the other thing that changed as the program matured was when we came in the program, no acute care stay could be greater than 72 hours. That changed to an average. So you could have someone in an acute care bed for 5 days as an acute patient, but maybe the majority of your patients were in there for 2 days or 2.5 days. So it became an average versus an absolute. We actually went through that exercise looking at those things that we did when we first joined the program to identify the types of procedures or medical conditions that always took more than the 72 hours. And we had to make a decision whether we could continue to do those or not. And I'm sure other critical access hospitals did that. So the regulations were changed over time. So with that, the number of critical access hospitals in Maine increased because of that.
So you must have 25 beds.
You don't have to, you're licensed for 25 beds.
Oh, okay.
Doesn't mean that you have to use 25 beds.
Okay.
That's the maximum amount of beds, hospital beds that you can have.
Okay. Now the current plan is to eliminate any kind of beds
Correct.
overnight and do away with the dietary staff. Now, is it possible in a critical access hospital to have a catered kitchen service?
You can, as long as they meet the regulations under the nutritional or the dietary services, they would, yes.
Mm-hmm.
In the situation that Lincoln County is moving toward, in some ways you don't need a dietary department because there are no patients there for an overnight stay. There'd be no overnight need. You might have some things, but folks would come in, get their service and then leave.
So,
They can always go to the ip tie.
True. Call out.
but it could be serviced, for example, from the kitchen at St. Andrew's Village.
And we did look at that. I'll tell you that we did look at, could one kitchen service both campuses? Dietary is an allowable expense. So you gotta be careful, because in some instances, when you took out expense, you took out revenue. That makes any sense to you?
Yes.
Yeah.
Just want to go back to the reimbursement structure, and I'm wondering how costs get defined for reimbursement. Are these some kind of contractual costs, or are they your actual costs?
No, they are actual costs. You'd be
Yeah.
looking at nurses' salaries, food. Housekeeping was by square foot now. But they were actual costs, and there was a formula if they were considered an indirect cost. Because, let me give you an example. At the end of the acute care wing at St. Andrews, we had a family room. And that family room was primarily for families to come and visit their patients, or patients to go down if they wanted to get out of their room. And we had a small chapel down there. Medicare would not allow the corridor that you took to go down to the end of the corridor to those rooms, because it wasn't strictly for those patients that were considered allowable costs, or not the patients, the staff. And so Medicare wanted to make sure that there had to be clear documentation of those things or persons or staff that was an allowable expense, and huge regulations on the finance part. Did that answer your question?
Yes.
Okay. Bruce?
So Peggy, as it stands now with the Lincoln County Healthcare Plan, on March 31st would be the last day that St. Andrews is a critical access hospital, and on April 1st it won't be?
I don't know the process to how you de-license. I have to assume, it sounds like it's fairly straightforward, where you notify the state, the licensing, that license hospitals, the department that licenses hospitals, and tell them you no longer meet those regulations.
And it would be very hard to get it back, I assume.
My assumption is that you'd have to go through what they call the certificate of need process to get that licensure back.
And that's, how difficult is that?
Well, in today's administration, they would like to do away with the certificate of need process. I don't know how difficult it is. I mean, it's not easy. It's better to keep it versus letting it go.
Yeah.
Is there a number of beds that you have to keep up to get maintained or prove that you need for the certificate of need?
It's much broader than that. You know, you do have to prove need.
Right.
And
And would that number interfere with what Miles provides?
Here again, I don't know.
Yeah.
I don't know.
Is there a mile difference between, if you want to set up a hospital, is there a mile distance that would inhibit getting that certificate of need, since there's some beds in Miles for that, or?
I think that might be a consideration
Yeah,
within the
I
certificate of need. I don't think it's based solely on that.
But is there a distance that you
I-
have to
I don't
be?
believe so. I
Okay.
don't believe so. But I've not looked at those regulations for quite a while now. So I don't know.
I've got some questions. One of the things we've heard is that it's not about the money, which of course means it is about the money. So I'm curious about the money altogether, across the board, at St. Andrews, and the Lincoln County Healthcare Annual Report does, in its appendix to the financial statements, include information as to the finances of St. Andrews for the past couple of years. I've been meaning to get them out and dig them out just to get a better feel. I've looked at them offhand for the last year or so. But could you comment about the difficulties of keeping, of how profitable or loss-making was St. Andrews during the time that you were CEO, and what was your impression of the prospect for continuing the hospital on a financial basis?
I alluded to that we had some very tough years because we, I guess you could say, overstated or understated our cost reports. Now, cost reports are done by the finance department every year that are sent off to Medicare and the state, and they look at those and they say, yes, we overpaid you, or we underpaid you, and the theory is they make up the difference. So the cost report was certainly one of the barometers we looked at, and we didn't do it well for the first few years of us being a critical access hospital. And at that same time, so that was 2000 when we opened the village. And so we overstated or understated our cost report numbers. Those were tough years. I think of the money that we knew that we were owed, and we made it through those years. The annual fund drive was a lifeline for St. Andrews. You know, on an annual basis, there were, here again, taxing my memory, probably it was, you know, $250,000, $240,000, $250 a year helped. The auxiliary, purchasing equipment, the fundraising that was done for a new hospital, those weren't easy financial years. But if you have good medical staff, good clinicians, you provide the best product that's appropriate for your facility and practitioners to do, you have the support of the community. And, you know, we would see up and down folks using St. Andrews. You know, when you have to pay out of pocket for a lab test, and I'm going to make up some numbers again, and it costs $100 to get a lab test at St. Andrews, and you could go to Midcoast and get it for $75. You know, you have to think of those things. So small hospitals will never be the cheaper charge structure, but they need to be competitive for folks in the community to use it.
Well, $250,000 a year, for example, sounds like a lot, but it isn't all that much compared to the costs, the total revenue that the hospital realizes. Hence your focus on the amount of funds that are made available by other means. But it seems to me that one of the things that's going on is an underestimation of the availability of funds from donations from people on the peninsula.
Oh, you mean moving forward?
Yes.
Well, I think too that if people are threatened with loss of services that they want.
They assumed would be
Right.
there forever, yes.
That fundraising effort is going to be much tougher to maintain.
Yes. Well,
So in answer to your question, they were tough years. I spent far more time figuring out and strategizing about the finances than I wished I had. And
you know, I know a good friend of mine was head of a recording studio he owned it in California. He also was the one of the founders of a startup that made a lot of money. He was talking to a venture capitalist, and she asked him, how did he like being the head of that studio? He said, "I like it fine." He says, I like everything about it except raising the money for it." And he says, that's an aspect of being CEO that I don't like. And she said, "Well, isn't that what a CEO does? Is there anything else of any consequence that they do other than raise money?"
I hope they do a lot more than that.
Me too.
Because if you don't have a pulse on the quality, the physicians,
Then you won't be able to raise enough money.
right, right. So there's a lot more. And how can you be part of the community? Community hospitals, and all hospitals in some respect, are intertwined in their community. But it's important to be part of the community. How can you do outreach, and how can you collaborate with community entities that make sense? Again, St. Andrews has no needs here, folks. It's the individuals that live and work in the Boothbay region that have needs. St. Andrews is only a means of providing those. And sometimes we lose perspective on that. And we're more fortunate than most communities that we have a very philanthropic community here. And that has been supportive of St. Andrews and many other entities for a lot of many, many, many years. So I think maybe we need to change our language a little bit. And what are the needs of the community? What does the community need? And how can St. Andrews be that vehicle, and it can't be it alone, to providing the needs of the community? So I think we need to change how we view this. Because if critical access hospital is maintained, the emergency department's going to be there. So let's change our focus here and look at what are the needs within the community.
I have another financial question. I noticed that St. Andrews carries debt that's quite a bit larger as a percentage of its revenues than is the debt carried by Miles. In fact, St. Andrews, even though it's got a smaller gross revenue, has debt of around $10 million or so. That's higher than the debt carried by Miles. Can you comment about where that debt came from and what it is and why it's...
One of my guesses would be that monies were borrowed for the John F. Andrews Family Care Center. There were no funds from...
I see. So it would be offset by the asset, which is that care center.
And the village.
Right.
Not the cottages, but the inn. Monies were borrowed there.
I see.
So I have to assume, making an assumption, that that's where some of that debt is.
Right.
Now, the cottages, as you know, are set up in a separate association. The land is owned by the St. Andrews Corporation, but the individuals in the cottage own shares within the cottage. So they're the share owners. And I believe it was a 99-year lease that the association has with St. Andrews Corporation. But I'm talking about the inn, not the cottages.
Right,
when
I
say
understand.
that. You had a question?
Yeah, actually I have two. One is medical liability insurance for physicians. Is that included in the Medicare and Medicaid reimbursement?
It is, now I don't know whether all or a portion of it is considered allowable, but there is a portion of that that would be considered allowable. I'm pretty sure.
And do these, of the 16 critical care hospitals, are the physicians who work in them insured? Is their insurance provided by the hospital itself, or does each physician have to self-insure?
If they're employed,
Yeah.
and the majority of hospitals in rural America are now employed, that's provided by their employer.
And when you were CEO, was that a big piece of your payroll?
It wasn't. We did not have OBGYN physicians.
That's big.
That's big. We didn't have neurosurgeons or cardiologists.
That's big.
It certainly was a piece of the budget, but it was never one of those things that I'm, oh gosh.
And you, just one last question, you said, we should think about what services we need, and I agree with you, but I'd like to ask you, as somebody who is very close to this and the CEO for many years, what services do you think we need on the peninsula?
Well, at the time, and I have nothing to think that has changed, that many of the services, if not all, that we had at St. Andrews were appropriate to maintain. Now, were there others I wish we could have provided? I would love to have provided some dental services or mental health services. I would love to have done some more preventative services in the community. How do you keep folks out of the facility? And really, that's the future. Is you're going to get paid for keeping people out versus getting paid for putting people in. But with many of those services, you had to do the financial model. And could you afford to do them? Because we were already providing the nuts and bolts, what I call nuts and bolts of healthcare. I didn't feel that we were doing anything that we shouldn't have been doing. So there's a foundation of healthcare services that I think are important. But boy, it would have been nice to do some other things. It costs. Many people don't go to a dentist because it costs so much. But there's nothing that's going to decline your health more than not having good oral care. Very few dentists take main care. Mental health, substance abuse. We're not the only community that has those struggles, but boy, it would have been nice to, how can you complement a primary care practice with those services?
Just a quick follow-on. There are a lot of people who go off the peninsula for chemotherapy, for dialysis, things like that. Would it be at all practical to consider?
But we did have oncology here for a while. We worked with oncology group out of Midcoast, which is a group out of Portland, and we couldn't do everything as far as chemotherapy agents, but we did those that were appropriate to do in the setting that we have. Always have to look, is it appropriate? What if something goes wrong? Do you have the backup plan? It's a huge thing to consider. That stopped soon after I left. I believe there was, it was difficult for the oncologists to be here. I think that was the reason. Dialysis, you have to look at the numbers. There's a dialysis unit in Damascotta. It's not owned by Miles, but it was Judy Tower and I worked together. She said, I'll take dialysis if you take the chemotherapy, the oncology piece. And so we agreed that, if the volume warranted it, and we have to do that business plan, folks. That's when we put together the oncology program, and they worked with a company that does dialysis. A lot of that equipment auxiliary helped with a lot of that, or individual donations.
Were there grants given for a lot of those services?
Sometimes grants aren't quite as easy flowing these days as they used to be. They want to see what you're going to use it for and how you're going to sustain it. So, and I always felt that you should never ask for a grant unless you had a plan on how you're going to sustain it, because those grants can go away awful fast. Jane.
Well, you just triggered a thought into my head. Peg, you think about capitalizing on what you do well, and we have a great rehab department. And if we were sending our surgery somewhere else, would it have helped if we'd had the CEO hit Penn Bay, Mid-Coast, and Miles and say, okay, we're sending surgery your way, but we'd really like to have clients come our way for rehab. So that sort of thing, those kinds of relationships are developed. Is that correct?
That's correct. And the folks that went out to market that, they didn't go to hospitals. They went to where are patients going. They made visits to those physicians. So it's not the hospital, it's the physician relationship that you want to have. The rehab department did do that, as well as home health. Home health might know that because they're visiting them, that so-and-so is going to go someplace to have a procedure done. And they could help in that effort in saying, just so you know, you do have an option. One of your options is to return to St. Andrews if you need rehab. We have a great department, So yes, I mean, those are all opportunities that you need to think about as you're looking at maintaining and growing any type of service.
I think you were CEO in 1996
Yeah,
when the merger agreement occurred.
with Maine Health, that's correct.
Was it
No, excuse me. It
with
was
Miles?
Maine. No, it was with Maine Medical Foundation. Maine Medical Center Foundation. There was no merger with Miles at that. There's never been a merger with Miles. St. Andrews is not merged with Miles today.
Okay. The Lincoln County Health manages.
St. Andrews
Yes.
and Miles. So what was merged or integrated was the management and the board, not the two entities. The one exception to that is that there was a, what's it called, Lincoln Medical Practice, the physician group. They created another group which employed the physicians for both St. Andrews and Miles. But the two entities are not merged.
Okay.
Does that change your question?
Well, it appears to me that if we want to remain as a critical access hospital, we've got to change that relationship.
The critical access hospital status could not be maintained if the two entities were merged. St. Andrews Hospital has critical access hospital status. They're not merged. Medicare, first of all, wouldn't have, they have to separate the finances because St. Andrews is a critical access hospital. Miles has a designation called Sole Community Hospital. We had that for a while, and that was a little different type of reimbursement. So when we gave up Sole, S-O-L-E, licensing status, Miles could then apply for that, but the two entities are not merged.
Okay. So the next question becomes, are you, in your consulting capacity, are you available to guide us through whatever process it takes to keep St. Andrews and as a critical access hospital?
If the needs of the community warrant the maintaining of that status, I think that that's a good reason to go after and maintain that. I think we need to start thinking a little bit differently
Okay.
about what it is the community needs and look at it from a population health perspective versus a maintaining the emergency department. Because if the needs say, yes, we should maintain an emergency department and we should retain critical access hospital status, then that tells our story the best way that it can. You know, we need to move to a more rational thought process. Because if you look at the Navigant report, it's a lot about finances, and it's much broader than that. So if the story is there to be told, I'll be part of the story, but I'm not going to be the story. There are very smart folks out there that are working on how to tell the story the best and what to look at. And I think it's incumbent upon all of us to be involved somewhere. Because once it's gone, you probably will never get it back.
That's right.
And it's not just a small group that's here on Tuesday. We need to hear more from the business community.
Yes.
We need to hear more from all ages of our population, because it's there for everyone. I don't know if that answers your question,
Thank
but
you.
that's how I perceive it. Yes.
Is there an approved or a format, a survey format or a questionnaire format that people doing a population health perspective would use to be able to gather all that information?
I think there's a lot of data out there, and it's finding the right data and how you can cut it and slice it that reflects this population. I'd love to think that we could have the finances to actually do, a phone survey. Then we'd get a better cross-section of our community. But that takes a fair amount of money, but it might give us good information. I think we need to make decisions based on the best data we have. We need to balance it somewhat with our emotions. So I think we need to come from a more rational thought process. But there's a lot of data. It's what's the best data to make good decisions with.
Would it be better to create our own data, like send a survey out into the community to see what they perceive the need?
I feel that that's a very specialized.
Okay.
But yes, I do think that that's a good way.
Do you think it would be feasible for maybe one of the agencies in the community to maybe sponsor a survey to be sent out to see what is available, or what the people want?
What do people want?
Yeah,
What are their needs?
like BCA or Rotary Club or somebody sent out that survey.
You'd have to identify an organization that does this.
Yeah.
You would want a very credible,
Right.
reputable organization that focuses at healthcare surveys and,
Is there any such animal?
Oh, I'm sure there is. I'm sure there is.
Surveys are, it takes, probably 4 or 5 years to train somebody to do a survey. It's not a simple process. And there are companies out there that do this kind of work. If we were to try to organize ourselves, I would just ballpark it at about $150,000 at the minimum to do a competent job here. So.
You know, I think that's a, how do, and if we can't afford to do that,
No.
what's the best next step?
Plus, we don't have time.
Right.
Yeah.
As he's
Right.
saying, 4 or 5 years.
I don't know whether there are a few final questions that people want to ask.
Well, I'm more than willing to state if there are questions. I just implore us to think more broadly and more strategically.
To slightly change the focus here, I learned an astonishing number today. It was astonishing to me, that the healthcare spending dollar on our peninsula is $40 million a year. Did I have that right?
Do.
Yeah.
40 million we spend collectively from the tip of Southport up through Edgecombe. $40 million a year on healthcare.
How did they get those?
So you can't tell me that we can't have a healthcare facility here to meet the needs that we are still in the process of
Yeah.
trying to define, not through a $150,000 survey that takes 5 years because we don't have the luxury, but maybe we can create something in the interim that will begin to move in the right direction. Clearly, the Lincoln County healthcare folks did not do that. They had a completely different model in mind. They probably have the same data that we would look at, but their interest was not in maintaining the kind of, when I sat here listening to Peggy, I thought, yeah, that's the kind of hospital we want, and that's the kind of healthcare facility that we want. And they could have, if they had said that, we want that here, they could have come, and if they'd surveyed the population and asked us what we needed, they probably could have come to a good decision, but they didn't. So we need to do that, but we don't have much time.
I think the Navigate report has good information in it. It's just incomplete as far as.
How can we see that?
It's right,
It's right there.
We have
Got it.
PowerPoint in
You have the
here.
PowerPoint.
It is available.
The whole thing, I want to see.
Yeah, I've looked at it, and it's
Where is it?
the report that you get when you hire somebody to give you a report, and they're smart enough to know what report it is that they should submit.
I know that.
Yeah.
I realize that. I still want to see it.
You're right,
How can we
absolutely.
see
No,
it?
it's you can
That's
see
right,
it.
Steve.
Okay.
It's the PowerPoint.
It's here, or you can see it online.
Yeah.
Okay.
It's the
Well,
I need the
PowerPoint.
reference, okay.
It may be the PowerPoint is their report, but, you know, it's certainly limited in what to.
Usually there's a fairly detailed written report that goes with the PowerPoint.
It's not there.
No, it is not. Yes?
I'd like to get your feedback on a proposal. What if, since we don't have $150,000 to spend in 5 years, what if we were to do a survey, as several people have recommended, that maybe some of it could be published in the paper, some can be mailed out to, residents, high school kids, elementary school kids, anyway, whatever we could get easily. Obviously, it would have to be short. It wouldn't be, a 50-page survey. It would be a 10 or 20 or 30 question kind of survey. But do you think if we did that plus interviews and phone calls with physicians, key business people, a random number of individuals in the community who are willing to participate, that we could gather enough information? I mean, I do those kind of phone interviews and face-to-face interviews for a living, so I'm happy to do it here, donate my time to do a bunch of them. I would just need to understand
Well,
what questions to
what
ask.
are the questions to ask?
Yeah,
I'm
exactly.
going to look at Andrew.
I don't know the town records well enough to know if we have a base there we could actually draw a random sample from. We could take a look at it. I'm not thinking it would be the most productive way to proceed, though. I think,
Do you have a plan or a productive way to see how to do this?
Don't forget, folks, that there is some existing data already.
Yeah.
There's a fair
Yeah.
amount of data.
So we may have to rely on what exists already that comes
Yeah.
from what's already been done. If we rush off and do a badly designed survey or tiny or minimal, it's a hard job, as Patty knows. It's not easy.
I think that there's enough information about the types of healthcare issues. It's finding the right place to look for those, and they've been done. They've been done. One Health Maine actually did a fairly comprehensive assessment. They're using Maine Health, Eastern Maine Healthcare, and I'm trying to remember if there was some other, whether CMMC was involved in that or Maine General, but and they looked at demographic information. I think it was county by county. Here again, you're pulling from my memory, folks. But those are the healthcare. And I've got to believe that the state must have some type of information about healthcare trends that could shed some light on the healthcare needs of the community.
Would the Muskie School be any help in reference to getting information for healthcare?
Go ahead.
Peggy's been in touch with them. I know I have too as a part of our work. They still owe some information that I hope they will send. I've got to be in touch with them some more. But yeah, there are people at the Muskie School that we're in touch with, and we will use whatever tools they have that they can provide to look at how we continue on after April 1st.
The Muskie School also does a lot of work for the National Flex Program. That's what we call it. We don't call it the Rural Flexibility Program, we call it the Flex Program. And they do a lot of work with North Carolina in doing reports on quality, challenges and opportunities within, the critical access hospital world. One of the other things that I guess that I think we need to recognize is that many of healthcare services that have had a hospital in their community, they're the foundation on which those are grown. Whether that can be good for a community. It also can be a challenge. Depends on how you want to turn it around. I really appreciate your questions, and hopefully I've shed a little light on. This isn't easy, folks. What everybody is trying to do, there are a lot of things to consider, but you need to move forward in some fashion based on the best information you have. And I think it's important to do it proactively, positively, and I think we've beat enough on each other. So let's take it what we have and let's move forward with it in a positive fashion.
And I will say that there's a kind of a focus group that's grown out of this group that kind of includes Peggy and Tom Berry, the attorney, and we're talking with a couple of potential helpers who can maybe help us do some of the things that Peggy's been talking about, which is think about the overall healthcare needs, look at the existing data, possibly do some kind of survey work, but unlikely, and come up with a concrete plan. That is the whole goal of this group, right from the get-go, was a concrete plan. I was calling it the community hospital, but it could be governed in any one of several ways, I assume. Community hospital being only one of, a public community hospital being only one way. But the idea is a healthcare institution in our community that's geared to meet our needs. That's what we're after.
Yes.
If you have questions after this is over, please feel free to call me, because sometimes you think, oh, did she say that? Does that make sense? Or because I know I got some of my dates wrong when we became a critical access hospital, and I'd have to go find that. Time flies.
Jim Donovan has put out in their internal newsletter for Lincoln County Health a statement that the reason we lose our hospital beds is because we lose the emergency room designation, and that is a matter of state law. Do you know what law mandates that a hospital have an emergency room? Couldn't we work with a critical care center that's there more wide open if that law were changed so that we could break that linkage with the emergency room?
There are 4 levels of emergency care. There's the tertiary, there's the secondary, there's the primary, and then there's the 4th level, which is this urgent care center. We're a primary, which in some ways it sounds like it should be reversed. But the state of Maine has, the EMS program has done a very good, Emergency Medical Services, which is a state organization, has worked with the hospitals to look at and identify the types of things that a primary hospital on average should be doing versus a secondary versus a tertiary. So there are some state requirements that are thrown in there on the levels of emergency care, but the lowest level of emergency care is what we have right now at St. Andrews, which is all critical access hospitals have. Anything less than that is considered urgent care. A secondary would be mid-coast.
Okay.
A
Tertiary would be Maine Medical.
A tertiary would be Maine Medical Center. Because you have to have certain types of physicians to fall under that secondary category. Maybe they do. I say primary real quickly, but I'm sure they're on that cusp of primary and secondary.
When the doctors, 2 doctors, 4A and Bob came to St. Andrews Village, and also the financial officer.
Wayne, probably Wayne.
Yeah.
Yes.
And, they kept saying things like, the emphasis is going to be keeping people out of the hospital. But then, on the other hand, they say it doesn't get used. So, and I say, knowing not much, but that the peninsula, at least, well, Buffet Harbor, anyway, is full of elderly people. Their main concern is if they have a crisis in the middle of the night or on the weekend, what do they do? I mean, I think they'd be afraid. And they want to get to a hospital where somebody knew what they were doing.
Well, I'm almost positive that there's a paramedic on 24/7 now. Yes, is that right? And I have a son that's an EMT that drives it on call on Tuesdays and Wednesdays. Timothy.
But I mean, I don't think, like people where I live, I don't think they're thinking as much as of keeping themselves out of the hospital. I mean, to be sure they don't go there for fun, but as they think about when they're really in bad trouble and they're...
Well, a hospital is very appropriate for a lot of things. But if someone has chronic obstructive pulmonary disease and diabetes and hypertension, what is it that they can do for themselves that would keep them as well as possible with those chronic diseases. And as we all get older, and we're going to have something, so how do we start today to stay as well as we can? And when we do have a chronic disease, how can we take care of ourselves so we don't end up going to the hospital? So probably hospitalization for most people is inevitable, but let's delay it as long as we can by taking as good a care of ourselves as we can. And you know, there are a lot of factors out there that make it very difficult. Maybe folks can't afford to go to the doctor, maybe they can't afford their medicine, maybe they can't afford the right foods to eat. I mean, there are a lot of things that get in the way of people staying as healthy as they can. So is there a way to work with individuals to help them so they get those things that they need to stay as healthy as they can? We're not going to eliminate that. But there is a real push looking at how do you take care of the population so it can be as healthy as it can be. You go down to the Y and you look at the folks that use the Y and the average age of folks down there, it's amazing. You know, we have, I think the Booth Bay region has a very healthy population overall when you look at the average age of the population. It's because we have things that are here that support, you know, whether it's good churches, you know, stimulating conversations at the library. You look at a community and what does it bring to the health of an individual? And a health is much broader than taking a pill or having a chronic disease. So all of those things need to be considered when looking at taking or working with someone. And you can't make someone do something that they don't want to do. But we can do a better job at assisting people in being healthy. But that takes a lot of money. They call them, this is my age, sorry. They call them case managers that you have a relationship with, that contacts you periodically that says, you know, were you able to buy the medicine that the physician ordered for you when you had an appointment a week ago? Have you stepped on the scales on a daily basis? What is your weight showing? You know, those folks that have congestive heart failure. For those folks that have mental, you know, some mental needs. Can they get their medicine? Are they going to see the therapist on a regular basis? You know, we can get very complacent with our health. I don't know if that answers your question. And they, on the whole, have an option to choose where they want to go. And, you know, option and choice is an individual's right. Unless there are mitigating circumstances where it is in your best interest. But overall, people have choice.
I just think that it's one of the amazing resources that we have to help us. Peggy is one of those amazing resources. And it gives me hope that we can focus on the right things and be successful in what we want to do. So, and as well as all of your interest continuing on. Thanks so much for coming.